introductory comments about Lewy body dementia, and then I'll introduce, or I'll allow the panelists to introduce themselves. Lewy body dementia, referred to as LBD, involves nearly the entirety of the nervous system: cognition, movement, sensation, special senses, autonomic function, psychiatric function, sleep, and arousal. And that's one reason that's so challenging to diagnose and treat it. It's a clinical syndrome encompassing two subgroups: those with dementia with Lewy bodies, abbreviated DLB, and those with Parkinson's disease dementia, abbreviated PDD. These two subgroups of LBD are defined according to the timing of the onset of motor features of Parkinson's disease relative to the onset of characteristic cognitive impairments. Because we still don't have a lot of information about the genetics, epigenetics, and other factors influencing the pathophysiology of LBD, it's diagnosed during life primarily on clinical grounds with a few diagnostic tests. All the methods of assessing LBD have limited sensitivity and specificity. In reality, Lewy body dementia is a syndrome which is expressed in vastly different ways among different individuals. And this is true even among multiple affected members of a family who possess the same highly penetrant genetic defect causing the condition. With that, I'll introduce the five panelists today, each of whom will take 5 minutes to discuss different aspects of LBD. Gary Schmidt is, there we go. We'll talk about the cognitive, motor, and psychiatric features. Vicki Setterberg, do you want to wave, Vicki? We'll describe autonomic and sleep dysfunction. I'll talk about the pitfalls in diagnosis. Marcia Sack-Trefman will describe the roller coaster aspect of living with dementia with Lewy body, or living with Lewy body dementia. And Sue Andrus will talk about quality of life. Okay, I'll turn it over to Gary.
Thank you. First of all, I'm a little bit intimidated by making this presentation to try to do it in 5 minutes and then to have two neurologists who specialize in cognitive disease watching me. So yes, I'm Gary Schmidt. I'm a retired family practitioner. Went to school, the University of Wisconsin, Madison. And then for those from Illinois, I do have some attachment there, doing my residency at the University of Illinois in Peoria. Went into family medicine and spent 37 years in the single practice up in Wisconsin. During that time, I always had an interest in long-term care and in geriatrics. And for 30 years, I was a medical director for a nursing home, which turned into a retirement facility for over 30 years. The retirement facility had multiple levels and actually had 3 different memory care units. And my office for the last 10 years was located in the building. So I had a lot of exposure to different memory deficits that people had, and realized how limited my education was. In that medical school, I can remember hearing about dementia, AKA Alzheimer's, and unspecified diagnosis, and motor dysfunctions of Parkinson's. When I took the CMA courses during my practice, you did a lot of geriatric training and went to 4 or 5 days of training where they'd have 1 day on dementia and maybe 5 minutes of that talking about Lewy bodies. So my education and my knowledge of that disease was very limited. And I realized how many times I missed that diagnosis when I was practicing. And now when you when I go up to someone and start talking to them about Lewy body dementia, they hear the word dementia, and where does their mind go? It goes to Alzheimer's. And when they think, they don't realize the difference between Alzheimer's. And as you realize, there's a vast difference in not only its pathology in the brain, but how it presents. A person with Alzheimer's is going to be living in the day that they're thinking. Their thinking is living in a day maybe 20 years ago. And when they're out of that time, they won't remember what they had done, what they had said. Person with Lewy bodies will remember those errors. They'll go to need to go to the bathroom, and they end up in the laundry room, and hopefully they don't use it unless there is a floor drain, which some of them do have, but then they'll remember it. Or if they can't remember their grandchild's name, or their where they just went out to eat at their favorite restaurant and they're driving home and they can't remember the name of the restaurant. You can tell them where they're at, where it was, but that what they had, what the menu was, but that name continues to slip them. And they remember those errors that they make. That leads to a high level of anxiety and depression, not knowing what's going to happen next. Is it going to be something, they're going to forget something really important? Are they going to say something that's really, really hurtful? And that makes it very difficult for them emotionally. Adding to that is something that Sarah is going to talk to in the future, is the difficulty in making the diagnosis. They often live with the fact that, well, we don't check all the boxes that make that diagnosis. And so you don't really know what you have. And so you're always left in the lurch. And if you remember Robin Williams and how he struggled for years not knowing what he had, and then all of a sudden on a basketball court, he showed up with a tremor in his hand, and voila, he has Parkinson's. Well, he was really struggling with not knowing what was going on with him. He thought he was going crazy, to the point where he hung himself. And it wasn't until 3 months later at the autopsy, his wife found out that he had Lewy body dementia. And you can just imagine what kind of anxiety that accrues on people. One of the things that you often find is you are doing something at home. You usually did the finances, or you had a series of things you did, and all of a sudden you're not able to do it. You had a series of things. You're getting ready to go to work or to get up in the morning, and you go into the bathroom, you brush your teeth, take a shower, shave, comb your hair, and leave. Something interferes with that. You get a telephone call, someone talks to you, or your mind wanders to what else is coming on in the day, and you slip up. And you walk out of the bathroom with your shirt tails hanging out, your hair not combed, your zipper not up, all those weird things that no one thinks about, but it happens, and it bothers you when it happens. And people say, well, that happens to me all the time. Well, does it happen to you 6, 7, 8 times a day? No, that's not the normal part of aging. It's something different. They also have the motor problems, where not only do you have balance problems and gait problems, but you have an energy level that isn't what it used to be. Going up a flight of stairs, you get 3/4 of the way up a flight of stairs, and all of a sudden your legs feel like, wow, I must have ran all day long. Or mowing a lawn. Last year it takes you 45 minutes. Today it takes you an hour and a half, and you have to rest several times. All these things, lead to concern, worry, not feeling good about yourself, and wondering what's going to happen, knowing that there's limited amount of medication or treatment that you can do that's going to help that. You know that it's It is a fatal disease that people will die from. People will die from at some point in time. Maybe, 5 years from now, the myth is that, I'm sorry, neurologists, but the myth is that when you tell someone they have Lewy bodies and now you got 5 to 8 years to live, from the time I told you this, it's not always true. People live much longer and the symptoms will show up much earlier than that. But you have that, I don't want to say death sentence, but you have that false idea that that all of a sudden you're going to gradually be decreasing, and it's going to be not going to be fun, and you're going to be gone in 5 years. So it's a complicated disease. As a physician, I have found it an amazingly interesting disease. It's so diverse and so varied. What one person has, the other person doesn't have. You just don't know, and it affects so many parts of your body. Very interesting, but it's really a field that family practitioners should go into, and not neurologists, because they can take a look at the whole body, the family, and it's not just the head. That's my pitch for family practice to the students. Consider it, and also consider the University of Wisconsin. So that's all I have to say. I know I went more than 5 minutes, and I apologize to the rest of you. So I think Vicky's next, right?
Hi, I'm Vicki from Iowa, and I'm 68 years old, and I have an undergrad and graduate degree in business, and that led me to owning a wellness company for 14 years. I was first diagnosed with MS 10 years ago by the first neurologist I saw, as I had a lot of pain in my legs, and I was having some tremors and a lot of balance issues. At that point, I had 3 white spots showing up in my brain MRI, and I was put on baclofen, and I was sent home, and I was told to come back in 6 months. And of course, I went home and I researched MS because I didn't know much about it, and I was terrified. I went back to the doctor 6 months later, and to my surprise, he told me I didn't have MS at that time. So I was very bewildered, and of course I went and got a second opinion. And that began my very long road of visiting different neurologists, and each one gave me a different diagnosis and new meds that didn't help me at all. At this point with Lewy body, I can't remember what all my diagnoses were, but all I know was that I kept feeling worse and I had more pain, and the spasms and the tremors never went away. Fortunately, my primary care physician knew that I was not a complainer and I wasn't a faker, because she had seen me for 20 years, so she knew me very well. She set me up with physical therapy, and I ended up with a therapist that had a PhD in physical therapy, and she ended up giving me a very thorough evaluation, and she immediately saw that I had a lot of complicated issues, and so she recommended that I go to Mayo Clinic. So she kindly called my PCP and told her that, and she also wrote a letter for me to send to Mayo Clinic. So between her and my PCP, I got to Mayo Clinic, and they did lots of tests, and they actually diagnosed me with giant cell arteritis, and they did a PET scan after a lot of tests, and I had 5 different chest and abdominal swellings, and they immediately put me on high dose prednisone. And I did start feeling better right away, but I did continue with mild tremors in my hands, and I still had a lot of balance issues. So the reason I'm kind of telling you this is just to kind of give you a history of all the medical issues that I've had in the past and leading up to my Lewy body diagnosis. It wasn't until 5 years after all of this that I started developing cognitive problems. I told all my friends that I was forgetting everything. I was losing my keys and my phone 20 times a day. I was misplacing things all the times, and they just kept saying, "Oh, you're getting old." but I know it's more than that. And after a year of them telling me, oh, you're just getting old, I finally talked to my PCP, and she ran an MRI, and it showed that I had 10 white spots on my brain. And so a neurology appointment was set up. That neurologist was very good at showing me the MRI and explaining that I did have brain deterioration, and that was showing up on the MRI. At that point, he diagnosed me with early onset vascular dementia and then told me to come back in 3 months. And as he got up from his chair, he told me to go home and get my legal affairs in order, and he started walking out the door. I asked him if I could ask some questions, and he gruffly said, "One." So I had all these things going through my mind, and all I could think of was I asked him how long I had to live. And he said it was hard to tell, but he gave me an answer of 2 to 8 years, and he walked out the door. Needless to say, I was in shock, but I left his office and I decided not to go back to him. And he did not let me ask any questions about my diagnosis, so I was pretty upset about that. But of course, I went home and I researched the whole internet, and I spent 5 days just researching everything about dementia. I couldn't find very much at that time. This is about 4.5 years ago. I couldn't find very much about early onset dementia, but I read all kinds of things about dementia, and that sent me into a severe depression. I wish he had given me a brochure with something about hope, especially for people with early onset dementia, or at least given me a referral to, there's a local support group in my town. I wish he would have given me a referral to that. It took me a whole year to find that support group. Through my research too, I did find that there were some medications that would slow my progress down of the dementia. So that made me even more frustrated that he didn't put me on one of those meds on that day that I was there. So I felt like I had wasted time. But I did eventually call and make the 3-month appointment. But when I called the neurology department, I was really hesitant, but I asked for a different neurologist. And they gave me another one, and she was fantastic. She was great. When I went in to see her, she put me on Aricept, and she recommended an antidepressant and counseling, which I did both. And she explained everything to me. She gave me hope. She was just great. I really appreciated her, and I told her that. I thanked her so much before I left the appointment. I was just grateful to her. The counselor that I went to, he explained to me that I was depressed because I was actually grieving all the cognitive things that I had lost. And so he walked me through the stages of grief of all the different cognitive things that I had lost. So that was very, very helpful. 2 years later, I think I started having my first symptoms of Lewy body, and the first one was probably an autonomic system issue. I started having big temperature changes, like every half hour I would go and I'd be hot, then I would be cold. And these things happened very quickly. And that summer, I ended up in the hospital for 7 days after I very quickly had heat exhaustion. I went out to my car, it was a very hot day, got in my car, it was very hot, and I had only driven a few blocks, and I started getting very sick. I was having nausea. I turned around and came home, and by the time I parked my car, I could hardly walk. I was so sick. I got in my house. I knew that I needed to drink, so I started drinking water. Fortunately, I had Gatorade. I started drinking Gatorade, but I got very nauseated. And then I couldn't keep anything down. And so I ended up in the hospital, and I got a very bad UTI also, and was in the hospital for 7 days with that. Then a year later, developed another autonomic issue, and I started feeling like I was going to faint every time I stood up. And I thought it was just because I was out of shape. So I just, I put up with it. But one day I fainted in my kitchen. So I called up my neurologist and I thought maybe I had a seizure. So she had me come in and I told her about some of the other new symptoms I was having. And some people in just the regular dementia support group I was in said, you sound like you have Lewy body. And I knew nothing about Lewy body, so I didn't know what it was. So my neurologist ordered an EMG and that came out fine. I had no seizures and not even any, it was just perfect. So she told me to get a cardiology workup, and she didn't seem too worried about it. And I even asked her if she thought my new symptoms were Lewy body, and she said no. So I set up my cardiology appointment. That took 4 weeks, and I still kept feeling very faint when I stood up. And on the way to the cardiologist, I fainted and fell in the cement and smashed my whole face up. I was a bloody mess when I walked into the doctor's office. The cardiology nurse cleaned my face up. It was bleeding profusely. The cardiologist walked in and was shocked. He took my blood pressure right away and it was extremely low. And he called the ambulance and said, "We're sending you to the hospital." I was totally shocked. Was admitted to the hospital, given stitches all over my face. They diagnosed me with orthostatic hypotension, and they told me it was a, what's the term? I've lost my train of thought. Someone help me out. It was what is the word? I can't remember. Anyway, so they did, what's the word I'm looking for? It's an autonomic problem. Well, anyway, so I asked for a referral to Mayo Clinic, and they had a whole neurological team see me. I had a variety of tests. I had a REM sleep disorder study, CAT scan, MRI, sweat test. And then they must have thought it was Lewy body because they ordered a PET scan. And I, of course, had a lot of labs. And that's where I was diagnosed with Lewy body in January of this year. And I still have that neural team. And then I also have a new neurologist because the one that I love dearly, she moved. And so now I'm seeing the entire team at Mayo Clinic, and I'm seeing a new neurologist here because I'm now having more autonomic system problems. I have low heart rate now. These are all relatively new. I have terrible shortness of breath, even though I've had negative lung x-rays. I have they've tested my breathing, that's came out fine. I have, I can't get any deep sleep, any REM sleep, which is very common with Lewy body. And I take melatonin every night, high doses. I have trouble swallowing, and I don't know if you can tell or not, but I'm starting to lose my voice. Whenever I talk for a while, I start getting very hoarse. I have a lot of urinary problems. I have difficulty starting urination, and I have trouble completely emptying my bladder. I've had a camera scope and everything came out fine. My newest symptom is I have clear urine at night when I get up. I usually get up 2 to 3 times and it's completely clear at night. And so that's my history of leading up to Lewy body and my diagnosis. And these are just my autonomic issues with Lewy body. And now Sarah's going to talk to you. I'm not sure what about, but anyway, I'll let Sarah talk to you now.
Well, as you can tell from the previous speaker, there's a tremendous range of symptoms, including perceptual, vision, tactile, other special sensory, taste, smell, hearing. All of those can be affected by sensory distortion or hallucinations. And the list goes on and on. So that the pitfalls in the diagnosis of Lewy body dementia are many. And I will mention some based on my family's experiences. First, I want to point to the limited scope in the current diagnosis for LBD. Historically, dementia studies looking at Alzheimer's disease were undermined by errors of inclusion. That is, people with dementia, but without Alzheimer's, for instance, those with Lewy body dementia, were not adequately excluded from their studies, and consequently, the study results were skewed away from a clear picture of Alzheimer's disease. So in light of these revelations, particularly the dementia with Lewy body investigators were intent on creating diagnostic criteria that excluded other conditions. One unintended consequence of their construct was excessive reliance on a very few objective laboratory tests, which for many individuals were not very sensitive or specific early in the course of the disease when compared to a careful history and exam. So as a result, as mentioned above, many patients are not diagnosed until they suffered with the symptoms for many years. Realizing this more recently, there's been a tremendous amount of interest in validating Lewy body dementia biomarkers for research and clinical use. So first problem is that of the nature of the current diagnostic criteria, the framework. The second pitfall in diagnosis is caused by the fluctuations which are characteristic of LBD. So the diagnostic criteria says that for dementia with Lewy bodies, people have to have unpredictable fluctuations in cognition and alertness. However, all of the symptoms fluctuate, particularly early in the course of the disease. And this is not universally appreciated. So for example, a person might have significant intermittent orthostatic hypotension, but when they present for autonomic testing and undergo tilt table test, they may not have what's considered a significant orthostatic drop. And oftentimes those persons' complaints are then dropped or dismissed. And that's a mistake given the nature of the disease. I believe that there is actually a phenomenon that is well discussed among caregivers for LBD, and they call it show timing. I believe in this phenomenon, and I think it refers to situations in which, in the presence of someone that the person with LBD wants to impress, they perform or are able to converse at a higher level than usual. I think this is analogous in many ways to the situation where in, a terrible situation, someone of normal strength is able to pick up a car and, off the person, another person who's trapped underneath the car and liberate them that way. So in other words, there's this tremendous flood of, energy in the form of neural conduction and neurotransmitter release that allows this tremendous effort. So I think something similar is occurring in show timing, in which with high levels of autonomic or limbic stimulation, the synaptic cleft is flooded with the neurotransmitter that is usually in short supply in that individual. And therefore they are able to carry out tasks that usually they can't perform. So perhaps this is a result of, the release of the pool, what do they call that? The reserve pool in the presynaptic terminal. I'm not exactly sure of what the mechanics are, but this is how I think of it as happening in my mind. And I think it really explains a lot of the phenomenology that we see. So what commonly happens that so frustrates families is that the person with LBD will, have this terrific component. They'll have just finished telling the doctor or somebody else about, what a fuddy-duddy the person is and how feeble they are. And then this person will walk really well or converse eloquently. And then they'll go home and they'll absolutely collapse at home. They won't be able to do anything. They're spent. And so I think that this is part and parcel of the disease. It presents as a difficulty for diagnosis. And I think that clinicians need to repeatedly challenge patients with Lewy body dementia with a task so that they can demonstrate that they actually have this post-challenge collapse, exhaustion, and it uncovers their deficit, which would otherwise not be apparent during a brief examination or brief trial. Okay. The third category of diagnostic pitfalls in LBD is I attribute to the vagaries of American medicine. And so for the last 30 years, it's been very difficult to get adequate time to perform detailed histories and examinations. As you know, it takes a lot of time to extract from a patient what their subjective experience is and try to fit that into a diagnostic framework that makes sense. Most of the time, the patient doesn't say, I have well-formed visual hallucinations of people and animals, which is, one of the major diagnostic criteria for the condition. Instead, the patient uses a lot of wordy, figurative language that's hard to interpret. And because of time constraints, neurologists rely increasingly on capturing pat phrases that help them arrive at the diagnosis. Unfortunately, not only does the examiner come away with an erroneous impression of the patient's problems, but the entire body of literature about LBD has suffered by the truncation of this information into overly simplistic pat expressions of the patient's experiences. By way of support for my opinion, a paper was recently published in Neurology Clinical Practice in which a panel of movement disorder specialists in Canada and the US were asked to interpret the open-ended free text responses of Parkinson's patients who were asked to describe their off periods, that is when their medication wore off. For the most part, these were motor symptoms. They were concrete motor symptoms and not nearly as intangible and elaborate as the myriad other symptoms that patients with LBD have. And despite this, the neurologists could only agree on a specific symptoms for 39% of the phrases that the patients used. So these are a select group of movement disorder specialists with a very, well-defined, not terribly time-constrained situation, and really figuring out what that patient is describing and trying to tell them is very difficult. So unfortunately, there's been an emphasis on laboratory data over subjective patient data. Even when the objective tests are insensitive. For example, let me just say that with something that's held as being fairly reliable, neuropsychometric testing can be interpreted as normal in someone with LBD because the deficits in LBD are not always that well tested. It's much easier, for instance, to pick up memory deficits on a short mini mental state exam or the MOCA exam, and even in-depth neuropsych testing doesn't really get a lot of the perceptual difficulties that confound Lewy body dementia. So other problems with neuropsychometric testing is a majority of patients aren't told to stop their cholinesterase inhibitor, which really affects the results you get on testing. Other things, for instance, just with neuropsych testing alone is norms are based on age, educational level, and assumptions about the patient's language ability. And so, for instance, if you quit school at 15, but you're smarter than most college graduates, you could be considered normal despite having significant visual, spatial, executive, and attentional deficits. And that's just one example of the objective tests used in Lewy body dementia. So people are working hard to come up with biomarkers that are much more useful in pinning down Lewy body dementia. I'd have to say though, spending the time to do a careful history is still very important. And I think one other thing that I want to express is my belief that a lot of patients encounter difficulty getting diagnosed because physicians feel that they are exaggerating or fabricating their complaints. And I think that in my own training, and I have seen this subsequently amongst doctors that my family's visited, that they are suspicious of historical information, patients' historical information, and that is a major form of implicit bias in American medicine today. So I'll leave it at that. Next, I think we have Marcia talking about the roller coaster.
Hi. I can't believe how much I'm learning. Thank you. I'm a retired clinical social worker and currently the care partner with my 82-year-old husband, Stephen, who has Lewy body dementia. I'm glad to be here today and really excited to see that there's a next generation of doctors that include men and women willing to take on the complexities and perplexities of living with dementia, and especially Lewy body dementia. Many of those with Lewy body dementia and those who have spoken today talk about the difficulty they had in getting a diagnosis. I didn't have that problem. We didn't have that problem. We were very, very fortunate. But I do understand why it's so hard. Lewy body dementia is a chameleon, and it's a sneaky chameleon. It presents as so many different things, and some things that first present seem very innocent. In our case, I think my husband has probably had Lewy body dementia symptoms for about the last 15 or more years. It began with just excessive daytime sleepiness. No matter what he did, he could not function without naps during the day, long naps. It was very hard. It was very frustrating for him and for me. We couldn't figure out what was wrong. So he went for a sleep study. Yes, he had sleep apnea. Yes, he had a CPAP machine. Yes, they told us about sleep hygiene. Yes, we did all the things that they said, and nothing helped with his excessive daytime sleepiness. About 3 or 4 years ago, so we lived with that for a long time, and it was very difficult. About 3 or 4 years ago is when the sleep apnea, the REM sleep disorder began to occur. And the sleep specialist told us that he needed to, he did not talk about Lewy body at that point, but he did, he did identify the REM sleep disorder, and he prescribed clonazepam. Well, one of the things with Lewy body people is that they're very, very susceptible to drugs. So at 0.25 milligrams of clonazepam, my husband did sleep the night, but he was sedated the whole next day. So that treatment went by the wayside and we stopped giving it to him. He did develop some hallucinations. And he, and I was getting more and more concerned. His memory also started to be memory problems also started to be more obvious. And he had gotten a diagnosis of mild cognitive impairment and depression. So he was then put on to rivastigmine and also then Lefaxine. And at that point, I began talking to our primary care physician about some of the things that I was reading about and what I was investigating and finding out. And he was a family practitioner like Gary, and he was and is a real jewel of a doctor. He listened. He knew us we'd been going to him for about 5-6 years. He did take a history. He did know all the things that my husband had been going through. There were a bunch of other physical stuff going on. And he agreed that we needed to look further for Lewy body dementia. So he made an appointment, or he made a referral to a movement specialist, movement disorder specialist. We had to wait for about 6 months to see her. There was COVID and we were new patients, and so it was very hard to get in. During that time, what we had discussed with our doctor was his balance was very bad. He walked with bent knees and a shuffling gait. He frequently choked while eating and had trouble swallowing. He had a wet cough, a frequent runny nose, and of course, the debilitating fatigue. So when we got the referral to the neurologist, I kept on making lists of what he was going through. And before we saw her, I sent her a pretty detailed list, not only of his symptoms, but also of his whole medical history. He lost his sense of taste when he was in his 20s and his sense of smell. I don't know what that has to do with anything, except that maybe he's had Lewy body problems for 60 years instead of 15. I don't know. But so he had that. And the thing that was bothering us the most was he was so weak. And doctors kept telling us, well, you sleep too much. You need to exercise more. And he just felt really horrible. He felt like he was really a failure. He was lazy. He was whatever. And the thing about Lewy body is when a person with Lewy body gets tired, you can see it in their face. You can't, at least I can see it in my husband's face. It just changes. There's no expression. The eyes kind of half closed, and you know that he has to sleep. So anyway, we did, having given her all the information that I possibly could about his current situation and his history, she was wonderful. She was very, clear that she had read everything very carefully and thought about it, along with the referral from our physician. And she did a very thorough clinical examination. She held a conversation with him that was sort of a freelance of any of the mental status exams that people, screening exams that people give, but it wasn't a set one. And she was extremely helpful. So I suspect that no doctor is happy about giving patients a diagnosis of Lewy body dementia, but I would suggest that presented with factually, but with hope, definitive diagnosis is a great gift, and it was to us. So no longer did we have to think that there was something we were doing wrong or something he was doing wrong. But she was able to really form a relationship with us and inspire confidence in us that she was going to be there, that we weren't in this alone. She talked about social workers consults if we wanted it. She talked about support groups. She did give us some brochures, but that wasn't the big thing that she did. She established a partnership with us. And, you know, Alzheimer's has a steady decline. Vascular dementia has sort of a stair-step decline. Lewy body dementia is a roller coaster. It goes up and down. You never know when it's going to hit, what it's going to hit. My husband is very capable of show timing, but this doctor was able to see right through it and redirect him, and just, you know, she knew what she was dealing with. And I think that as aspiring doctors, it's so important if you listen to the patient, but also listen to the caregiver and realize that they can really pull things off. And you might think there is nothing wrong with them, but you'd be wrong. There is something really, really wrong, and they will need your help and your support. So thank you all.
Thank you so much, Marcia, and thank you so much, everyone, for speaking and sharing your stories, sharing your experience. We are going to open it up now for questions. If students have any questions, we have the panelists here available, obviously. Like I said, Dr. Neelam Agrawal, who's a Rush cognitive neurologist, is also available for questions. I'll start, if you don't mind. I have a question. Multiple of the panelists had mentioned this phenomenon of show timing, and how, in addition to the many other things that has made Lewy body dementia historically one of the most misdiagnosed diseases, especially neuro-related diseases, show timing is one of these phenomena that make it so hard to diagnose it. How would you go about kind of teasing out that a patient is show timing, and maybe uncover that's what's going on?
I'm going to tell you that as a caregiver, that we sometimes will actually record our loved ones so that we can show people what actually is going on, because we even have family members who don't believe us. And so if we can do it without anybody realizing, without our loved one realizing it, we will record things, and then we can show that to people.
Okay, thank you. Yeah, that makes sense.
And I think the other thing to do is to listen to the person that's with them. Make sure that you don't just have the patient there, you have the caregiver who can give the answers correctly, where the patient may not be able to, and to listen to that person and to accept what they have to say.
Thank you. Are there any other questions? If anyone wants to put them in the chat, or just unmute yourself.
Andrew,